Good morning, everybody. Could everyone hear me well? Fabulous. So this is really a pleasure, and thank you, Jason, for those perfect introductory words. I certainly don't need to introduce myself to this crowd, but as an equity practice, I'm Elka Jacobson Dickman. I feel very comfortable with my colleagues calling me Elka, and my pronouns are she, her, and hers. So today, I'm really privileged to talk to you really a very introductory session about the learning environment and medical education. Does not seem to be in sync, so let me do it this way. There we go. So in thinking about this session and what I really wanted to accomplish, I always try to think of what my sort of core idea is. What is the crux of the learning environment, the common thread, if you will. And in thinking about that, I thought about something that Brene Brown said at the AAMC Learn, Serve, Lead last year in their virtual conference. And what she said was, fitting in is about assessing a situation and becoming who you need to be accepted. Belonging, on the other hand, doesn't require us to change who we are. It requires us to be who we are. So belonging, to me, that's the most appropriate word to encapsulate what a nurturing learning environment looks like. So what do I want to accomplish in this session? I'd like to review what I consider the key elements of the medical learning environment. I'd like to discuss the intersection of learning and the mentor-learner relationship, how we can best create psychological safety and avoid the impact of shame for our students, how we can bridge generational gaps in an effort to cultivate our relationships and to best serve our students' learning process, how we might be able to role model professionalism, and in that discuss the formal or explicit versus the hidden or tacit dimensions of the medical student educational process, which, as you know, is also known as the hidden curriculum. And finally, I would like to talk about imposter syndrome and how creating a climate of inclusivity could help preclude our students from feeling this way. But before I dive in, I'd like to begin my talk with a little etymology, as arguably any good talk should. And let's discuss the word hospitality. Does anybody know the Latin root for the word hospitality? Somehow I feel Dr. Friedman might. No? Okay, well, if he doesn't, nobody do it. It's auspice, okay? And this means guest or stranger. One can define hospitality as the friendly and generous reception of guests, visitors, or strangers. And truly, this virtue is rooted in so many, if not all, our ancient cultures. In Nepal and India, hospitality, or guests, I should say, were considered or likened to gods. In ancient Greek folklore, hospitality was a rite. And these themes come over and over again in Islam and Judeo-Christian cultures and onwards. But let's say that doesn't speak to you. Has anybody seen this Broadway show, Come From Away? Okay, so for those who haven't had the privilege, and it is recorded and available online, I believe, through PBS. This is a wonderful show about a very dark time in our history. It took place during the week of 9/11. And it took place in a town called Gander, Newfoundland. And what happened was, of course, America had to close down our airspaces, and planes that were heading towards the States had to land emergently. And this very small town found themselves with 38 planes landing, 7,000 individuals, effectively doubling the population of their town. They came out in droves. They literally gave food from their pantries and food off their backs. They welcomed strangers into their homes and just gave them whatever they could and whatever they needed. And they were celebrated around the world for displaying this wonderful virtue of hospitality. And in fact, it's the only place outside the US to have been honored with being given steel from the Twin Towers for the virtue of hospitality. One's main characteristics: respect, understanding, helping. Now, let's move away from the word hospitality. Or, excuse me, one more comment. Let's say it doesn't speak to you. Let's say I'm not a Broadway buff. I don't care about ancient cultures. I live now in this. Think about the virtues by which you were raised. This is Dr. Maxine, Dr. Stephen Jacobson. They raised me and my family and my siblings. And I'll tell you that in our family, no matter how you felt about somebody, when they were under your roof, you treated them with respect, understanding, and helping. So the bottom line is, think just about the basic values by which we were raised. And now let's move away from the word hospitality and think about the word hospital. Now, I'm sure you know, what is the Latin root of the word hospital? Hospes, again, guest or stranger. And these definitions of hospital have actually evolved. Initially, in late Latin, it was guest house or inn. It was only centuries later, by the mid-1500s, that it was started to resemble the definitions we use today: institute for the sick or the wounded people. And in fact, we do think about our hospitals as our homes, don't we? When we're here, when we're on call, what do we say? We're in-house. And I would say that these etymologic commonalities are really no coincidence. We treat our patients like guests, don't we? I would posit that our students likewise should be treated with this respect, help, and understanding, right? They are on a professional journey and here, in a sense, temporarily as our guests. Now, what happens to our patients and their education if they're not afforded a nurturing learning environment? Well, a suboptimal clinical learning environment is associated with adverse patient care and learning outcomes. And on the flip side, quality learning environments, as described by trainees, are associated with improved quality of care that they provide their patients even years after graduation. It's associated with better prescribing patterns and patient management outcomes, use of health resources, and correlated with lower surgical complication rates as well. So you can think about your efforts to improve the clinical environment, not only having a positive impact in the setting where trainees learn and participate in patient care, but also the practice of our future graduates and potentially for decades to come. So we've talked about the virtues, we've talked about a few outcomes. So what is the clinical learning environment anyways? Well, when this started being discussed along with professionalism competency in and of itself, it sort of had an amorphous structure. People thought of it as the climate, as the atmosphere in which students learn. It later became more appreciated as fundamental, the roots, the foundations with which they'll flourish. Of course, as we need to study and improve outcomes, we need to have better definitions. So for example, in 2018, Macy Foundation described the clinical learning environment as social interactions, organizational cultures and structures, and physical and virtual spaces that surround and shape participants' experience, perception, and learning. To bring it back to a very simplistic structure, you can think about it as an inherent overlap between work and learning. That's our clinical learning environment. And when things overlap, when realms overlap, we expect a certain level of congruency, of participation, and also some competition. In 2018, the Royal College of Physicians and Surgeons of Canada hosted a global consensus conference on the clinical environment. And they published the outcome of this conference and their discussions a year later. And what they did is they siloed sort of these realms of the clinical learning environment into 6 silos. And they called this the avenues framework, okay? And this was based on historical foci of learning environment study. And it included the architectural aspects, digital, diversity and inclusion aspects, educational or curricular, psychological, and sociocultural avenues. So for this session, I'm going to focus on diversity and inclusion, psychological aspects, and the sociocultural aspects. And the diversity and inclusion will be expanded over the day with our session on trans and non-binary inclusive learning environment, and later, of course, with Dr. Carla Booten-Foster's session as well. So to begin with, I'm going to delve a little bit into psychological aspects or avenues of the learning environment. And I'll start with a theory of learning called the cognitive load theory. And for those of us who are not familiar, I'll explain. This is a balance of intrinsic load, extrinsic load, and germane load. So what are these loads? Intrinsic load is defined by the actual content of the session, the ease or difficulty of those skills, knowledge, etc., that we're expecting our students to accrue. Extrinsic load is those factors outside the material itself that may distract from the intrinsic load. So for example, alarms going off, okay, lack of privacy, or jargon, using words that are distracting because they're not well understood by the learner. And what is germane load? Germane load I found quite interesting. So this is the mental energy or the emotional state with which the student uses or is facilitating the student's accrual of knowledge, of commitment to memory, and solidifying in the long-term memory, if you will. And that's something very, very entwined in the learning environment. So conceptualizing cognitive load theory is critical to our appreciation of the learning environment in our learners' educational process. And when we think about germane load, their mental energy, their emotional state to commit knowledge to memory, I think we need to think about the role of our relationships with our students. And I love this article. I'm sure you've heard me mention it before. It was a very simplistic article in the New York Times that I think speaks to this by David Brooks. And it was titled, "Students Learn from People They Love." And what he talked about was a moment in his teaching experience. He's an adjunct professor at Yale University, where he actually needed to cancel a class. And instead of just sending out an email or some kind of blast, he went to the class and he explained to the students why he had to, and it was for a personal situation in his home, and that was it. And he canceled the class. And he said that was a pivotal moment in his dynamics with his students, such that he felt he became a better teacher for them later. They were more engaged, they were more interested, they were more aligned. Before I read Pat Lee's paper on leading with love, I always felt a little bit like I had to defend using the word love, like maybe it's not appropriate in a professional setting. But Patrick Lee, who you may know is our inaugural chair of medicine at One Brooklyn Health, wrote this article, Leading with Love, 5 Practical Tips, and he defined love in a professional setting as the quality of attention with which we lead, with which we teach. And I thought that was really spoke to me and made me feel very comfortable using the word once again. And he said, it's possible to lead with love and discover abundance among teams who feel safe, cared for, and aligned towards a common purpose and their own professional growth. And here's an example that's a little bit more extreme about sharing and about the impact it can have on learners. And this came from an invited commentary by Dr. Darrell Kirch. That name may be very familiar to you. He is a past president and CEO of the AAMC. He also was the dean of 2 major medical schools in the United States. So I think by our standards, had a very, very successful academic career. And he wrote this commentary called Physician Mental Health, My Personal Journey and Professional Plea, where he discussed very, very personal aspects of his own struggles with depression, anxiety, and even suicidality. And I'm going to read to you an excerpt because I think it has an impact and is worth the time. He said, tragically, on more than one occasion, I received a phone call informing me of the terrible news that one of my students had died by suicide. I now wonder what the impact would have been if, as part of my greeting to the new medical students each year, I had shared the story of my own mental health crisis and successful treatment as a first-year student. I have to believe that seeing their dean share such a story might have been remembered by those students who died and might have led them to seek treatment rather than take their own lives. This is an extreme version of how sharing can have a downstream impact on germane load. And my last quote before I move on from the importance of cultivating our relationships with our students comes from Daniel Tosteson, who is the dean of Harvard Medical School for over 2 decades. And he said, we must acknowledge that the most important, indeed the only thing we have to offer our students is ourselves. Everything else they can read in a book. Nowadays, he may have said everything else they can read online. And to me, this is, one of our main arguments why we want our students in our classrooms. We want them in the labs. We want them in our conferences. We don't want them on Zoom. We don't want them getting everything they can from the books, because our relationships help their germane load. They help commit these knowledge and skills to long-term memory and practice. So I'm going to move on to a different concept in a psychological avenue of learning environment, and that's psychological safety. So what is psychological safety? I know many people in sort of a colloquial way say, oh, this is a safe space, this is a safe space. What does that really mean? What is it? Just to say something's a safe space doesn't make it a safe space. This is a perception of the consequences of taking interpersonal risks in a given context. That's a definition. It is not stable. It is dynamic and it is fragile. And why is that important? It's important because it's not one and done. It's not something you can do at orientation and think you're off the hook. It is really something that needs consistent work. But it's worth it, okay? Outcomes show that good psychological safety leads to improved creativity, engagement, performance, and learner-oriented behaviors. That's speaking up. That's asking for help. That's admitting that they're wrong and sharing assumptions that led to mistakes. Michaela Colby led a group who tried to sort of explain and give some structure to psychological safety. And while this was really focused on debriefing during or after or in the middle of simulation experiences, I think that it's really translatable what they came up with. And what they did is they separated the skills of creating psychological safety into implicit and explicit strategies. So implicit strategies, much like we teach our students when it comes to patient care, are the non-verbal cues. It's how do you set up the environment, right? Are you always at the head of the table? Is it circular seating? Is there something hierarchical or perhaps overt in the power dynamics that you can smooth out, if you will? Okay. Do you show them the respect of being on time, perhaps even arriving early, of respecting their time, of making eye contact, of giving empathetic nonverbal cues? All the things that we should do with our patients and really just in life anyways as a leader. And what about explicit strategies? As the name implies, it's being overt, letting people know what to expect, normalizing these experiences. It's not about you having done something wrong. It's the process. This is how we learn. This is ongoing. This is repetitive. This is our privilege as mentor teachers. And I thought this was quite complex, but also very helpful. Now, does anybody remember this show? Scrubs, right? So this show came out when I was an intern. So when I was an intern, these guys were interns as well. And this is a picture from the pilot. I don't know if anyone remembers this scene, but it really spoke to me. So essentially they get paged, their code beeper goes off, and the narrator is saying, the code beeper, whoever gets there first gets to run their code and save a life. And it's very dramatic. You see them running down the halls like, a la Chariots of Fire. And you're thinking that they're running, of course, to the code because these are really competitive individuals and they want to be the one to save the life. As it turns out, they meet each other in the supply closet because they're running away from the experience. And I remember at the time, like literally spitting out my water. I found this so relatable. But of course, this is not what we want, right? We want our students running towards experience. If they're going to learn, if they're going to be the best doctors serving our communities here on in and cycle this forward, we need them to run to experience and know that if they fail, that's okay, that we have their back and that does not make them a failure. They need to be allowed to make mistakes. Now, what if we don't create psychological safety and our students feel shame? What are the outcomes of that? Well, medical learners who experience shame are more likely to withdraw from others, to hide, literally and figuratively, to deny responsibilities, to ignore problems, and to respond angrily. Residents who have been shamed were more likely to experience severe burnout symptoms, including depersonalization, depression, isolation, and poor job performance. Shame causes avoidance behaviors and harms students' confidence, their motivation, their learning, and professional identity development. And lastly, in the concept of psychological avenue, I want to talk about bridging generational gaps. Again, this is at the heart of Germain Load, of nurturing our relationships with our students, of creating psychological safety. We're working in an incredibly diverse time in terms of our generations. We might be side by side with generations spanning 5 eras. Most of our learners, our trainees, our even junior colleagues in some cases are millennials. And are millennials different than us? Of course they are, because every generation is different, right? But they've gotten kind of a rap, haven't they? I mean, you guys have heard the stereotypes. They're so entitled. They don't work as hard. They're overly sensitive. They can't take criticism. They're always on their smartphones. Maybe some of us have participated in these stereotypes from time to time. Probably not super helpful in cultivating our relationships and building trust. And let's not forget, we've all been on the receiving end of generational stereotypes, right? So, for example, what is this picture of? Anybody know? So this is how our parents got to school, right? Up the hill in the snow, both ways. Perhaps they didn't have any shoes. And the millennials don't like it. I don't blame them. This has led to a backlash. Maybe you've seen these sort of internet sensational, these memes of like, okay, boomer. They're not buying it. They're not accepting the inferiority complex that some of us maybe time to time are conferring. I get okay boomer from my kids all the time. I'm not even a boomer, but I get it. So instead of naming negative characteristics, let's think about the context, right? When we think about the context in which people were raised, in which they were growing in their formative years, it might be easier to understand their characteristics. And if we understand their characteristics, we can do our jobs better, right? We can teach them better. We can nurture their professional identities better. We can serve our communities better. So what is that context? Well, these are learners who were raised during the digital age. They do not remember, or perhaps are not alive pre-internet. As a result, they're very tech savvy. Okay, they will transition way easier than most of us to a virtual age of patient care, of education, of artificial intelligence. They embrace multiculturality and diversity as a way of life, as an important virtue. They were raised in the post 9/11 geopolitical environment. They're very empathetic. So instead of thinking about these stereotypes, let's think about characteristics that we can work with that make us better teachers. They're self-confident. They're tech savvy. They're very optimistic. They're collaborative. Now, again, I don't want to paint an entire generation with one brushstroke, but if we think about these common threads, we can capitalize on them. So how can we optimize the learning environment in this sense? We can offer value, make it explicit. Why do we learn a certain thing? Why do we do a certain thing? You know, we struggle with some tasks we ask them to do that are mundane. Hand in this paperwork, that paperwork. Let's explain why it's important, how it contributes to their development. Much more likely to be successful in timely submissions. That immediate gratification of the internet. Feedback can't be once in a while. It has to be all the time. The mentorship has to be consistent. Diversity and inclusion. This is so important to our learners. This is our mission. This needs to be overt in almost everything we do. And something a little different that I don't believe we were offered is physician-centeredness. Okay, we know about patient-centeredness, right? That's something we all have in common. Our students feel it too. They try their best as well. But what about physician-centeredness? We need to think about balance, right? This is something I don't think we were afforded, but it's important to them. And if we don't consider them as individuals, their wellness, their time, we'll lose them. We just simply won't have a workforce going forward. And of course, and this is more administrative, we need to support our clinical teachers. If people don't have time to do all these things we would like them to do, they simply can't do it. And that has to come from the top down. Okay, so now let's dive a little bit into the socio-cultural avenue of this framework and talk about the hidden curriculum. So likely everyone in this room is aware of what I'm talking about when I say the hidden curriculum. But I think that Abraham Verghese said it best, in a sense. He said that students undergo a conversion in the third year of medical school, not preclinical to clinical, but pre-cynical to cynical. And I think that kind of says it all. But if we're going to really define it, I think Fred Hafferty, who was part of our symposium in September that we participated with our GME partners, he was really at the forefront of defining the professionalism competency. And he described the hidden curriculum as a set of influences that function at the level of organizational structure and culture, the understandings, customs, rituals, and taken for granted aspect of what go on in the life space we call medical education. It is responsible for much of future physicians' professional identity formation. We can liken the hidden curriculum to the front stage and the backstage. And Dr. Eisner, you may remember Francisca Nuoke actually introduced me to this particular concept years ago. She's one of our graduates, EM trained now from Yale University. And she talked about this quite a bit in her resident as teacher development session, which she created as a medical student. And really, what is this? You know, what is the front stage versus the backstage? Is anybody here a performer, a dancer, a thespian, a musician? I'm sure some of you are, at least in your hearts. What happens when you're out on stage? Okay, what about this dancer? There's a posture, right? You know you're being watched. You're incredibly conscious of being watched. Every action, every moment is calculated. And then you go backstage and what happens? You relax. And that's okay. That's human. In medicine, you're being watched, whether you're on stage or you're backstage. And if your behavior relaxes to the point where you're unprofessional, where you're disparaging, where you're not respectful, where you're stigmatizing to your learners, to your colleagues, to your patients, you're still being watched. And that behavior will be absorbed because you're a mentor and somebody looks up to you. And that's how they fit in. If they behave that way, they'll feel that they belong. And so why do we have to always be the teachers for professionalism? Well, because it's one of our 6 core competencies, of course, and it is the most difficult to just teach. Role modeling is the most common and the preferred method of professionalism education. And of course, what are these virtues and attitudes of professionalism? Some were excellence, altruism, compassion, duty, accountability, honor and integrity, and respect. And we need to display these whether we're in the front stage or in the call room or in the cafeteria or anywhere considered the relaxed backstage. And one can say that a low-hanging fruit is language, okay? And by low-hanging fruit, I don't mean easy. Nothing is easy to be done well. What I mean is that it doesn't take resources. It's something you can do on your own successfully if you want to. And so what is inclusive language? This is the intentional use of words and descriptors that welcome the diversity of all people and their identities. It means we avoid vocabulary that promotes stereotypes and stigma or reinforces dominant norms around gender, gender identity, race, ethnicity, age, ability and disability, sexual orientation, and socioeconomic status. For example, hello, my name is not my addiction. I am not my disease. I am a person who has a condition. What we know is that there are certain diseases that give an impression or that are perceived as things, as conditions or disorders that people have control over, or that they're even culpable for having. Substance use disorder is a very good example. People are named addicts, right? They're not often not referred to by a person who has a disease called substance use disorder. So for example, you might read a history of present illness like this. Mr. Smith is a 23-year-old substance abuser attending a court-ordered treatment program. He has been clean until 1 month ago, when he had 2 dirty drug screens and then blew a number on a breathalyzer. Mr. Smith's father was an addict as well. This might seem egregious, but it's actually not uncommonly seen. Abuser, we're using language that connotes violence. The fact that it's court-ordered is irrelevant to his medical care and biasing. Why do we refer to a toxicology screen as clean or dirty? we would refer to urine as sweet or bland. No, it's positive, it's negative, or it's quantified. Blue a number. Again, this is colloquialisms from criminality, from law enforcement. And calling someone an addict, he's a person who has a disease called substance use disorder. Once again, this is just one example. So in terms of diversity and inclusion, what does this encompass? And I don't want to be overly simplistic, but one can think of it as acceptance of and respects for the attributes of individuals along socially meaningful dimensions of difference. Again, fitting in is a belonging. It's who you are. It's not about changing who you are. And when we do feel we need to change, that's when people experience imposter syndrome. So what is imposter syndrome? This is a psychological pattern in which an individual doubts their skills, talents, or accomplishments, and has a persistent internalized fear of being exposed as a fraud. This is very pervasive in medicine, and it is not correlated with the accomplishments of an individual or their competence as physicians. And I'm going to give you an example if I could. So a few years ago, in my previous life at Maimonides, I ran another symposium for faculty development. And one of the sessions was called Airway, Working with Hospital Stories. And this was led by Myrta Rogel, who many of us know, was here serving for many years as an educator, and colleague Joshua Schiller. And we invited people who have stature in our communities, in our academic communities, to share narratives. One of those people was actually Jean McCrae, who shared a very beautiful story of her own struggles and messages therein. The other was somebody from our community at the time who was considered an academic giant in the New York landscape, if you will, and I don't think I'm exaggerating. And he shared his feelings of imposter syndrome, okay? He said, people sometimes say that I'm smart, that I have a lot of knowledge. I have no knowledge. That's why I read so much. I'm constantly reading to make up for my lack of knowledge. And so people think I have knowledge. We see this circular argument, don't we? The room was aghast. This is somebody everybody looked up to, okay? The jaws dropped that this person feels imposter syndrome, much like many of them felt themselves. And it was really a beautiful share and really, really prismatic of how pervasive this is, even among people at the very top. And who was this person? This was somebody who many of us know well. That's right. This was somebody who was a former chair of medicine here at Downstate, and this was Stephen Kamholtz. Stephen Kamholtz unfortunately passed away during the initial surge of COVID. So imposter syndrome is associated with multiple burnout indices and comorbidities, such as depression, anxiety, somatic symptoms, and social dysfunction. So it is very serious. It's not just something that's uncomfortable. It is more common among women and those self-identifying with an underrepresented group in medicine, including racial, ethnic, gender, LGBTQIA, religious, and other minorities. As I mentioned, there is no difference between performance of imposters versus non-imposters. And I'm going to not dive into inclusivity right now because we have two other sessions that are going to do so, okay? Not because it lacks importance. And I'm going to offer some concluding remarks. So to optimize the learning environment, in summary, we need to recognize, I believe, the importance of balancing cognitive load. We need to focus on nurturing our learner relationships, to learn and practice creating psychological safety, which includes bridging gaps and respecting or even admiring generational diversity. We need to role model professionalism in the front stage, in the backstage. And we have to continuously cultivate a climate of inclusivity and belonging. Our students come to us oozing with altruism, and that's what's motivating them. We don't want to do anything to dampen that as their primary motivator. Remember, the root of hospital and hospitality is the same, hospice. And if that doesn't speak to you, just remember the basic virtues and values with which we were raised. Thank you. I invite anybody to make comments or share anything or ask any questions that you think I or someone else in the audience can answer. Or any reflections. If not, I think we'll probably take about a 10-minute or 15-minute break. Thanks so much, you guys.